everybody else, all my friends from Vietnam. I am here representing the IASP, the International Association for the Study of Pain, which we are an association with chapters in about 70 countries or more, maybe more. And we are waiting, very excited that the Vietnam chapter, the VASP, Vietnam Association for the Study of Pain, will soon become a chapter of the IASP. We have to congratulate Professor Chung, Professor Hong, and all the other members of the society for forming your Vietnam Association for the Study of Pain. We know that there have been other, your Ho Chi Minh Pain Society and the Hanoi Pain Society and Hue Pain Society existing in Vietnam for many years. And so we are very excited that now you have managed to form one pain association for the whole of Vietnam. As Professor Chung has said in his welcome speech that was shown on the slide earlier. So we, as one society for the whole country, you can then apply to be a chapter of IASP. And all of you here are also welcome to become members, individual members of the IASP. And I think that maybe we can give you the information about how to be a member later on. You can, membership of IASP is $25 a year, so it's not very much for us in this part of the world if we are from what we call low and middle income country. So we pay $25 a year for membership, and you have many benefits, including you can apply for some fellowships and grants. It's competitive, but you are eligible to apply, and you also can get reduced rates for attendance, for registration fee at the IASP Congress, which is held every 2 years. And the exciting news, the good news is that the next IASP Congress, the World Congress on Pain, which will be held in 2026, will be in Bangkok, Thailand, and Dr. Sasikan will tell you about it afterwards. It will be in October, in 2 years time in Bangkok. So it's very close by, and you will be able to attend it without having to fly to the other side of the world. And most of the time, all the World Congress is held very far away from us. So it's very difficult for us to go because it's very costly to fly there. But if it's in Bangkok, then it's only 1 hour flight from here, 1 hour and 15 minutes flight, and also from Hanoi it's not so far. So please do join the IASP, and there are also a lot of educational materials on the IASP website. So you have lectures and you have courses that you can look at. And you can also have the journal, access to the journal page and the journal pain reports for free. Okay, so I hope to see many of you becoming members of the IASP, and we hope to welcome VASP, the Vietnam Association, as a chapter of IASP. And also we have a smaller group in this region which is called ASEAP, the Association of Southeast Asian Pain Societies, and we have a conference every 2 years as well. So the next conference is in Singapore in May next year, and we hope that we will also see our Vietnamese friends there. So on behalf of IASP and Professor Andrew Rice, who is the current president, I thank VASP for inviting me to be here, and I would like to congratulate all of you for being such an active, I can see a lot more activity now in terms of pain management in Vietnam, and we are very happy to see that, and we wish you all the best in your future work in developing and promoting pain management in your country. So with that, I will go into my lecture, which is how to manage chronic pain effectively in developing countries. Actually, how to manage chronic pain effectively in developing countries is the same as how to manage chronic pain effectively in any country, right? But I will focus on what are the specific challenges that we face in developing countries. So these are my disclosures. I have received honorarium from a few different companies for giving lectures and for participating in some advisory board. But I also, I have no conflict of interest for this lecture. So I'm going to start with some introduction about some basic concepts about pain, just to remind you. I'm sure you all know it already, but just to remind you and set the context. And then I'm going to talk about the need for interdisciplinary pain management. And when we try to do it in our context in developing countries or in low and middle income countries, I'll be using the two terms interchangeably. LMIC, low and middle income country, and developing countries. There are many challenges that we face. So what are these challenges that we face? And then I'll talk about how we could try to overcome some of these challenges. And I'll give you some examples of how we did it in a few different countries before concluding. So we all know the definition of pain. It is recently been revised in 2020 by the IASP, not big revision, but it's been revised to say that pain is an unpleasant sensory and emotional experience that was always there. So it's a sensation, but it's also emotional, and it is an experience. So each person will experience it differently. It's associated with or resembling that associated with. So it's as if there is tissue damage, either potential or actual tissue damage. So this is the official definition of pain now. And if you see at the bottom there, you can get this from the IASP website, and you see that there are some notes associated saying that pain is actually a personal experience, and you should believe a person's report of pain. We also know that there's this phenomenon called nociception. So nociception is a process by which pain gets from the periphery up to the brain. Okay, so the conduction of impulses when the nociceptor fibers are stimulated, okay, and it goes up to the brain. But that is just the physiological process. What the patient experiences is pain. What a person experiences is pain, and nociception and pain are not the same. Okay, so nociception, pain is the experience of pain is influenced by your beliefs, your mood, by cultural factors, by other illnesses, by your past experience, and by social factors as well. And all this actually influences what you experience as pain. So nociception is the physiological process, pain is what you experience. And this is what we call the biopsychosocial understanding of pain. Okay, so this is the biopsychosocial. So it's not just a biological phenomenon, which is the pain pathway, nociceptive pathway, but also psychological, your mood, your beliefs, and social, how other people around you respond to you when you have pain. So all this influences your experience of pain. And this is what we must remember all the time when we see a person with pain. I also want to remind you that we have acute pain and chronic pain. I'm supposed to talk about chronic pain management today, but we must know that chronic pain is different from acute pain. Acute pain is associated with tissue injury. chronic pain is a disease where there is no more tissue injury. Chronic pain can be divided into cancer and non-cancer pain, and the nociceptive neuropathic or nociplastic pain are the different mechanisms by which we can classify different types of pain. So, just going through some basic facts about pain. Chronic pain is a disease of the nervous system, of the pain conducting system, and it is not a symptom of underlying disease. Acute pain is a symptom. When you have acute pain injury, there is some underlying tissue injury, whereas in chronic pain there's no more tissue injury. And if you see this here, the WHO has recognized chronic pain as a disease in ICD-11. The International Classification of Disease 11th edition has got chronic pain as a disease, either chronic primary pain or chronic secondary pain. And I don't have time to go into details, but again, you can look it up on the ICD-11 website. The treatment of pain in developing countries is often inadequate. So a lot of people in our part of the world do not have good pain management, and it's up to us as healthcare professionals to improve this situation. We know in order to manage pain properly, we need to take a multidisciplinary or interdisciplinary approach, which has been shown to be the best way to have the best outcomes in the management of chronic pain, especially. Both acute pain and cancer pain also should be managed using a multidisciplinary approach, but for chronic non-cancer pain, it is actually most important to take this approach. So what is a multidisciplinary, multimodal approach to the management of pain? First, it starts with an assessment. So you need to assess the patient. You need to find out what kind of pain the patient is experiencing. Okay, is it acute or chronic cancer or non-cancer, and nociceptive neuropathic or nociplastic? Then you make a pain diagnosis. Then only you think about your treatment. And there are various treatment modalities. All of us know sorry, it's not moving. Oh, is it not moving? Oh, it's moving there, but it's not moving for me. Okay, so we have drugs, pharmacotherapy. You have interventions, injections that we can do, and there are a lot of sessions in this conference on interventions, all the different interventions that you can do for chronic pain. Okay, there's physiotherapy, there's occupational therapy, there's surgery, there's also psychological therapy, and in our part of the world, a lot of people also use traditional and complementary medicine when they have pain, especially when they have chronic pain. So remember that the important thing in the management of pain is that you have a person in the middle, and this is what you are treating, and your goal of treatment is to improve function and quality of life. So I'm saying this because when a person has acute pain, you want to relieve pain so that they can go back to normal function. But when a person has chronic pain, you do not necessarily need to take the pain away before this person can improve in function, in mood, and have a better quality of life. Okay, so there's a lot of evidence of the effectiveness of multidisciplinary pain management. As far back as the 1990s, we already know that it is more effective than single modality or single operator managing patients with chronic pain. Okay, so chronic low back pain, osteoarthritis, cancer pain, there are a lot of studies, and again, I don't have time to go into details, just to know that there is a lot of evidence for the effectiveness of multidisciplinary or interdisciplinary management of pain. And yet, the situation in our countries, in many developing countries, is that this is not multidisciplinary, multimodal pain management, especially for chronic pain, is really not the dominant model. A lot of people, single practitioners, They use only one or two modalities, medications and injections, for example, and a biomedical or curative. We still try to cure pain when it is chronic, which we cannot. It's like diabetes. Diabetes you don't cure, you just control. Okay, so in chronic pain, you talk about pain managing the pain rather than eliminating the pain or curing the pain. And yet, we often use what we call this biomedical model. So rather than a biopsychosocial model. So this table just tells you the differences between the biomedical or acute pain and the biopsychosocial or chronic pain model. In acute pain, pain is a signal of tissue damage and the patient can be ill. Whereas in chronic pain, pain is no longer a signal of tissue damage and the patient is not really ill. It's like the patient has a chronic disease like diabetes, but is not ill and can actually go on with their normal functions. The goal of treatment in acute pain is pain relief, whereas in chronic pain, the goal is to improve functions. The responsibility of the patient to get is an active one in chronic pain, whereas in acute pain, it's us doctors or healthcare professionals who have to do all the work. So remember, chronic pain and acute pain. So the first thing you have to do is make a diagnosis. Does this patient have acute pain or chronic pain? In order to know what kind of treatment you are going to give to this patient. So what happens in our part of the world, in developing countries? We have many challenges in setting up pain services. Before I go into the challenges, I just want to go into the definitions, and again this is available on the IASP website. What is multimodal, what is multidisciplinary, and what is interdisciplinary? Multimodal is the concurrent use of separate therapeutic interventions with different mechanisms of action within one discipline. Okay? Multidisciplinary is multimodal management given by people from different disciplines. Interdisciplinary though is what we want to promote, which is multimodal treatment given by a multidisciplinary team, but the multidisciplinary team collaborates with each other, talks to each other, has discussions and has a plan, a common plan for the patient using a biopsychosocial framework. Okay, so we are promoting the use of interdisciplinary pain management as the most effective way to manage chronic pain. There are many people involved, not just doctors. The whole list of doctors is there, but there's also nurses, physiotherapists, and so on, and pharmacists, and so on and so forth. The patient and family should be part of the team and part of the decision making. And as I said, it is collaborative care. Okay, we talk to each other, we make a common plan. So this is something that we need to change the way that we practice. Often we just see the patient, then we tell them, this is what you should do, this is what I will do for you. Okay, in chronic pain, we must make the patient realize that they are the ones, the most important person in their own management. They have to take charge. And so we teach them what we call self-management techniques, which I don't have time again to go into. So what are the challenges faced by us in setting up this kind of services in our countries? Okay, there are many challenges, and this was just a list that I got from this article by Pong Paradi Chowdak Setrin from Thailand, who was one of the early pioneers of pain management in Thailand, in Southeast Asia. So pain services are not a priority. Our governments are more interested in reducing mortality from communicable disease, maternal and child health, and so on and so forth. Okay? They are not very interested in pain because pain doesn't really kill people. So it doesn't go into the national statistics of deaths. So they are not so interested. We have limited resources. All of us have limited resources. In this part of the world, we have limited, especially for pain, relevant for pain, we have limited number of clinical psychologists. We have a heavy clinical workload. We see many, many patients every day, and we just have 1 or 2 minutes or 5 minutes for each patient. And And importantly, the biopsychosocial understanding of pain and the concept of chronic pain and pain management is not taught in medical schools or to other health professionals, but we also, and for us, we need to learn it as something new, and also we need to teach it to our colleagues. So, Professor Hong, the time is up, but I'm not going to listen to the time because I gave my speech in the beginning, right? So I'm going to take more time. So the last but not least is interventions. Putting needles into people are actually very attractive to everybody, to the patient who wants a quick fix. So you give them local anesthetic, they get pain relief, they are very happy. You are also very happy because the patient is very happy. Okay, but it's a short-term solution, and the patient with chronic pain must remember it is a disease, which means that it is a long-term problem, and we need to actually find long-term solutions for them. Other challenges that I think are existing with us is that we have to work in a team, and working in a team actually takes a lot of time and effort. You need to know the members of your team. You need to build up your team. If you are going to set up a service on your own, you just have to go and find a room, find a space, and set up your service. But if you need a team, you need to train your team, you need to do a lot more things. Okay, and you need to get rid of, in our part of the world, we are very hierarchical. So I'm the boss, you just do what I say. Okay, but when we work in interdisciplinary teams, we are all equal. Each of us brings our own expertise, and each of us will contribute our own expertise to the management of the patient. And the patient themselves is also very important. In our countries, at least, a lot of patients say, I don't know what to do, doctor, you do for me.